Chamber clear. We now come to urgent and emergency care recovery plan. I call the Secretary of State for Health.
Mr. Speaker, today we are publishing our new delivery plan for recovering urgent and emergency care services, which has been deposited in the libraries of both houses. After the scale of the pandemic pressures, which healthcare systems around the world and indeed across the UK are collectively facing, we are building the NHS back to where we want it to be. This requires the widespread adoption of innovation, building on best practice already being applied in specific trusts, together with significant investment in these new ways of working, including a £14.1 billion funding boost to health and social care, as set out in the autumn statement. Today's announcement is the second of 3 plans to cut waiting times in the NHS. Our elective recovery plan is already in action, virtually eliminating the backlog of 2-year waits in England. And our primary care recovery plan will be published in the next few weeks to support the vital front door to the NHS through primary care. And today, together with NHS England, we are setting out our plans to reduce waiting times in urgent and emergency care through an increased focus on demand management before patients get to hospital and greater support to enable patients to leave hospital more quickly. That will be through care at home or in the community, supported with a clinical safety net. And in addition, this plan sets out how we will adopt best practice within hospitals, learning from those trusts that have displayed the greatest resilience in meeting the heightened pressures this winter. Mr. Speaker, today's announcement on urgent and emergency care does not sit in isolation. It is part of a longer-term improvement plan building on the legislative change enacted last year to better integrate health and social care through the 42 integrated care boards. Those became operational in July last year. This in turn was prioritised for additional funding through the £14.1 billion announced for health and social care in the autumn statement. Now, following the spike in flu cases over Christmas, with inpatient flu case admissions 100 times that of the previous year, and that spike having extremely quickly a 7-fold increase into December, we announced £250 million of immediate funding on the 9th of January for the pressures this winter, giving extra capacity to the emergency departments to tackle those patients fit to leave hospital who are delayed from doing so. Today's plan, developed in partnership with NHS England and social care partners, builds on those actions and that investment as they set out to the House earlier this month, as we put in place the more substantive changes required to enable the NHS to have greater resilience this time next year. To do so, this plan involves embracing technology and new ways of working to transform how patients access care before and after being in hospital. That in turn will help break the cycle of emergency departments in particular coming under significant strain in winter. Mr. Speaker, our plan has a number of commitments that are both ambitious and credible. First, we are committed to year-on-year improvement in A&E waiting times. By next March, we want 76% of patients to be seen within 4 hours. In the year after, we will bring waiting times towards pre-pandemic levels. Our second ambition, Mr. Speaker, is to improve ambulance response times, with a specific commitment to bring Category 2 response times, those emergency calls including for heart attacks and strokes, to an average of 30 minutes by next March. And again, in the following year, we will work to bring ambulance response times towards pre-pandemic levels. I'm pleased the College of Paramedics has welcomed the plan, saying, quote, "It is pleased to see a strong focus in the recovery of those people in the Category 2 cohort. And of course, this will not be the limit of our ambition, but it is vital we get these first steps right and that we're credible as well as ambitious. To put these targets in context, achieving both would represent one of the fastest and largest sustained improvements in the history of the NHS. Underpinning these promises, Mr. Speaker, is one more essential commitment, a commitment to better data and greater transparency. On data, the best performing hospitals have benefited from the introduction of patient control centres to quickly identify blockages in a patient's journey, and e-bed management systems to speed up the availability of beds when they become free. Through this plan, we will prioritise investment in improving system-wide data, both within the integrated care boards and on an individual trust and hospital site basis. This will allow quicker escalation when issues arise and a better system-wide response when individual sites face specific challenges. On greater transparency, for some time, voices across the NHS have called for the number of 12-hour waits from the time of arrival in A&E to be published, something I know the Royal College of Emergency Medicine has long campaigned for, and I can see the Honourable Lady nodding her head. And indeed, there has been criticism, including from the benches opposite, of the government for refusing to provide this transparency. Instead, the data published to date has been a measure of 12 hours from the point of admission and not arrival in A&E. Mr. Speaker, for the commitment to transparency to be meaningful, we must be prepared to publish data even when that transparency will bring challenges. And so today I can inform the House that from April we will publish the number of 12-hour waits from the time of arrival. Dr. Adrian Boyle, President of the Royal College of Emergency Medicine, previously said, and I quote, "The full publication of this data will be an immensely positive step that could be the catalyst for transformation of the urgent and emergency care pathway that should help to improve the quality of care for patients." And I hope it is a transparency that is welcomed across the House. Mr. Speaker, our plan focuses on 5 areas: setting out increased capacity in urgent and emergency care, growing the workforce, speeding up discharge, expanding and better joining up new services in the community, and making it easier for people to access the right care. Action in each area is based on evidence and experience, learning lessons from the pandemic and building on what we know can work. More than that, we're backing our plan with the funds we need, and the government is committed to additional targeted funding to boost capacity in acute services and the wider system. That is why, Mr. Speaker, this package includes £1 billion of dedicated funding to support hospital capacity, building on the £500 million we provided over this winter to support local areas to increase their overall health and social care capacity. Taken together, Mr. Speaker, this plan will cut urgent and emergency care waiting times. It will do so, firstly, by increasing capacity with 800 new ambulances on the road, of which 100 are new specialised mental health ambulances. This comes together with funding to support 5,000 new hospital beds as part of the permanent bed base for next winter. Secondly, by growing and supporting the workforce, and we are on track to deliver on our manifesto commitment to recruit over 50,000 nurses, with over 30,000 recruited since 2019, and the NHS will publish its long-term workforce plan this year. We're also boosting capacity and staff in social care, supported by investment of up to £2.8 billion next year and £4.7 billion the year after. Thirdly, by speeding up discharge of patients who are ready to leave hospital, including freeing up more beds with a full rollout of integrated care transfer hubs, like the kind of successful approach I saw this morning at the University Hospital of North Tees. Fourthly, by expanding and better connecting new services in the community, like joined-up care for the frail elderly. This includes a new full service, so more elderly people can be treated without needing admission to hospital. Virtual wards are also showing the way forward for hospital care at home, with a growing base of evidence showing that virtual wards are a safe and efficient alternative to being in hospital. Our aim is to have up to 50,000 people a month being supported away from hospitals in high-tech virtual wards, of the sort that Watford General Hospital has been pioneering, which I saw last month. Finally, Mr. Speaker, we're improving patients' experience by making it easier to access the right care, including a better experience with NHS 111 and better advice at the front door of A&E. So patients are triaged to the right point within the hospital without always needing to go through the emergency department, as is currently the case at Maidstone Hospital, as I saw earlier this month. These are just some of the practical improvements already being delivered in a small number of trusts, which through this plan we will adopt more widely across the NHS, and in doing so deliver the greater resilience ahead of next winter. Mr. Speaker, I'm pleased that NHS Providers has welcomed today's plan and that the Royal College of Emergency Medicine has called it, and I quote, a welcome and significant step on the road to recovery. Taken together with all the other vital work happening across health and care, including our plans to cut elective and primary care waiting times, today's plan will enable better care in the community and at home, and for that care to be more integrated with services in hospitals and for existing practice to be more widely adopted. I commend this statement to the House.
Shadow Secretary of State, West Streeting.
Thank you, Mr. Speaker, and can I thank the Secretary of State for advance sight of his statement. Mr. Speaker, after 13 years of Conservative mismanagement, patients are waiting longer than ever before. Heart attack and stroke victims are waiting more than an hour and a half for an ambulance. 24 hours in A&E isn't just a TV programme, it is the grim reality for far too many patients. 7.2 million people are waiting for NHS treatment. Why? The front door is broken, people are finding it impossible to get a GP appointment, so they end up in A&E. At the same time, the exit door is broken because care in the community is not available. Patients are trapped in hospitals, sometimes for months. And in between the two is a workforce that is overstretched, burnt out, ignored by government ministers and forced out on strike. Does this plan even attempt to get patients a GP appointment sooner? No. Does this plan restore district nursing so patients can be cared for in the comfort of their own homes? No. Does this plan see ministers swallowing their pride and entering negotiations with nurses and paramedics? No. And does this plan expand the number of doctors and nurses needed to treat patients on time again? No. The Health Secretary said a lot of things, Mr. Speaker, but he did not say when patients can expect to see a return to safe waiting times. His colleague, the Minister for Social Care, rather let the cat out of the bag this morning. She was asked, and I quote, "Is there any plan at all for when we will get back to 95% of patients in A&E being seen within 4 hours?" She responded, and I'm not joking, her answer was, and I quote, "I can't tell you that." Ridiculous. How can he claim his plan is ambitious and credible? What kind of emergency care plan doesn't even attempt to return waiting times to safe levels? It's a plan that is setting the NHS up to fail right from the start, a plan for managed decline. These targets are not plucked out of thin air. Patients waiting more than 5 hours in A&E are more likely to lose their lives. So are heart attack and stroke victims waiting more than 18 minutes for an ambulance. Sadly, that is exactly what has happened this winter. It is what happened this summer, and it has been going on since before the pandemic began. The 4-hour A&E waiting time target hasn't been met since 2015. The only time the Conservatives have met the 18-minute target for ambulance response times was during lockdown. What's his ambition now? 30 minutes. 30 minutes waiting for a heart attack and stroke victim to receive an ambulance when every second counts. Isn't it the truth that they miss the targets, so they are moving the goalposts, fiddling the figures rather than fixing the crisis? And he boasts that he's pouring more money in, £14 billion, almost as much as his department has wasted on dodgy, unusable PPE. Yet standards are being watered down. So can he explain why patients are paying more in tax but waiting longer for care? Why is it that under the Conservatives we are always paying more but getting less. So what is their answer? I quote again, "There are so many people in hospital who wouldn't need to be there if we could provide quality care at home. Medical science and technology offers a world of possibility for the NHS to transform patient care. Virtual wards allow people to receive hospital care at home." End quotes. Those aren't the Secretary of State's words, Mr. Speaker. That's my party conference speech. He didn't have a plan for the NHS, so he's nicking Labour's. Now, I'm happy for him to adopt Labour's plans, but here is what he missed. You cannot provide good care in the community, in people's homes, or in the hospital without the staff to care for people. That is the supermassive black hole in his plan published today. People. Virtual wards without any staff isn't hospital at home, it is home alone. So where is his plan to restore care in the community? Labour will double the number of district nurses qualifying every year. So can he hurry up and nick that plan too? And of course, good care in the community is not a substitute for good care in hospital. We need both now. So why, in the middle of the biggest crisis in the history of the NHS, with hospitals so obviously short of staff, is his universities minister writing to medical schools to tell them not to train any more doctors? This is ludicrous. Labour will double the number of medical school places and create 10,000 new nursing and midwifery clinical placements, all paid for by abolishing the non-dom tax status. Now, I know, Mr. Speaker, the Prime Minister might not like that last bit. The Prime Minister might not like that last bit. They're all complaining opposite, but they didn't complain when they put up income tax, Mr. Speaker. The Prime Minister doesn't like it, but perhaps this would be a good time for the Conservatives to act tough on tax dodgers. So when is he going to nick that plan? And when is he finally going to get his act together and end the strikes in the NHS? Or perhaps I'm speaking to the monkey when the Chancellor is the organ grinder. If that's the case, Mr. Speaker, then when will we get a chance to question the real Health Secretary on the strikes this one is causing in the NHS? Labour will create more front doors in the NHS. We will tackle the crisis in social care. He offers sticking plasters, and by now, Mr. Speaker, it's very clear only Labour can offer patients the fresh start the NHS needs.
Well, Mr. Speaker, he started off by thanking for advance sight of the statement, and then gave a series of remarks that simply ignored what was in the statement. And even his last point just shows how riddled with contradictions the approach from the opposition bench is. He says in interviews that he supports the pay review body process. That is the official position, or at least was. Then he says, no, we should be negotiating individually with the trade unions and disregarding the pay review process. So there's no consistency on that at all. He talks about operational performance. You just had your go. You can hear the answers. He says that it's about operational performance. And I, Mr. Speaker, my remarks try to be fair to the fact that actually these are challenges that are shared across the United Kingdom. They're shared globally. He seemed to think that these were just unique to England alone, and yet you only need to look at the fact more than 50,000 people in Wales, notwithstanding it's a smaller population, but more than 50,000 in Wales are waiting over 2 years for their operation, when we cleared that in the summer in England with fewer than 2,000 in that cohort. He talks about workforce, Mr. Speaker, obviously didn't bother to read what we said in the statement. We're on track to deliver our manifesto commitment of over 50,000 nurses. We've got over 30,000 so far. If one just looks compared to last year, Mr. Speaker, 10,500 more nurses in the NHS this year compared to last year. Now, the grown-up position is to recognise, well, the first 5 years we were dealing with the letter that said no money was left. So, you know, so the first 5 years were indeed... They don't seem to like the response, Mr. Speaker, but the facts speak for themselves. 10,500 more nurses this year than last year. But the grown-up positions is recognise that we have an older population, they have more complex needs, and the consequences of the pandemic are severe They're severe in England, but they're severe across the United Kingdom, in Wales and Scotland, and indeed in other countries across the globe. He says that the statement didn't cover the plan for GPs. Well, again, I was clear that this was one of 3 plans. We had the elective plan in the summer, which hit its first milestone. We have the second component today in terms of urgent and emergency care, and we will set out in the coming weeks through the work that my colleague on the front bench is doing, our approach in terms of primary care. And that is the approach that we're taking. It keeps chantry 30 years. We didn't have the pandemic 13 years ago. So, of course, we... well, I can only surmise, Mr. Speaker, that he didn't quite get his remarks right, which is why he feels the need to keep chuntering now and have a second, a third and a fourth go. But perhaps next time. On ambition, he ignores the fact that we need to balance being ambitious but being realistic, and these metrics are, in the view of NHS England, their fastest sustained improvement in NHS history. So clearly he is at odds with NHS England in those remarks. On funding, we're putting in an extra £14.1 billion of funding into health and social care over the next 2 years, which reflects the fact that, notwithstanding the many competing pressures that the Chancellor faced at the autumn statement, he prioritised health and social care alongside education as the key areas that were prioritised, notwithstanding the other competing challenges. And on virtual wards, I hadn't quite realised that he was the clinician that had invented virtual wards. I actually think the credit for virtual wards goes to the staff such as those I met at Watford, who are the ones who are driving forward that innovation. And it's slightly strange that he wants to sometimes claim ownership of something that has been clinically led by those working at the front line. We have recognised its value, and that's why both at Northeast this morning or Watford last month or on various other visits, I have been discussing as to how we scale those virtual ward plans.
Chair of the Select Committee, Steve Bryan.
We look forward to going through the plan with the Secretary of State in detail when he comes to the Select Committee tomorrow. Could I just ask him about the ambition on the 2-hour response to frail and elderly with falls at home to prevent them from being admitted into the acute sector? Obviously, this was committed to in the long-term plan, he will know. What does he need to put this ambition into practice?
Well, we have earmarked the funding as part of the 2.8 billion next year to put that in place. Actually, I think one of the key things is less the funding and the accuracy of the data. It's to be able to see where there are gaps in coverage, how we get the right levels of community response. That is something that ICBs have been set up to take an integrated approach on. And I think one of the best enablers of that will be the control centres that the ICBs will set up, which will allow us to get much greater visibility of where that has been delivered and how we escalate it when it's not.
Rachel Maskell.
Thank you, Mr. Speaker. 300,000 vacancies in health and social care means that his plans, whatever he puts on the table, will never be delivered. So what is he doing to retain the burnt-out, traumatised staff that currently work in the NHS and to resolve their pay dispute and to put enough money on the table to pay social care staff enough to come and work in the service?
Well, we recognise the huge pressure there is on social care. That is why, at the autumn statement, the Chancellor set out the biggest ever increase in funding, 7.5 billion over 2 years, into social care of any government. So we are putting more funding in. In terms of workforce more generally, the Prime Minister has committed, as has the Chancellor, to bringing forward the workforce plan, which will set out the longer-term ambition on workforce, and for that to be independently verified. But in addition, we are recruiting more staff, and I updated the House whether it's the 3% more doctors this year compared to last year, the 3% more nurses, the increase, whether it's 40% more paramedics compared to 2010, the 50% more consultants compared to 2010. We are recruiting more staff, but I think the grown-up position is to recognise that there is also more demand.
Sajid Javid.
Thank you, Mr. Speaker. I warmly welcome the plan set out by my right honourable friend today. However, he will know that one of the reasons that emergency care faces so much pressure is because successive governments have not focused enough on the prevention agenda. And indeed, last week's news that the government will not be going ahead with individual focus plans on cancer, dementia and mental health has concerned many. So can I ask my right honourable friend just to assure this House that when it comes to the government's new major condition strategy, that it will be published promptly, it will be comprehensive and significant?
Secretary of State.
Well, I'm very happy, firstly, to give my right honourable friend that assurance. But I can reassure the House that our commitment to the missions through the Office of Life Science, the cancer mission, the dementia mission, is absolutely that commitment is there. He's right, we are bringing that together in one paper because I think we should take a holistic view of our approach. But I absolutely share his ambition in terms of prevention. I think what I set out in early January was the three-phased approach, which was the immediate response to the pressures we saw from the flu spike over Christmas, the 250 million. The second part of that is what I've just announced today. How do we build greater resilience into the system looking ahead to next winter? And the third element is the major conditions paper, which is around the prevention piece, which is bringing forward the very innovative work that colleagues through the Office of Life Science are doing, and how do we bring that forward into actually impacting the front line of the NHS much sooner than might otherwise have been the case.
Barclay.
Thank you, Mr. Speaker. I want to raise the case of a constituent who described to me the state of Salford Royal A&E earlier in January. She said, "My partner was taken by ambulance yesterday at about 11 a.m. He has a severe chest infection and breathing problems. He was left sitting in a chair on oxygen till 10 p.m. when a trolley was found for him to sleep on. There are no beds available. My constituent said that patients and staff feel that no one cares. After such a long wait, my constituent's partner was found to have pneumonia and he's been very poorly. Now the Secretary of State is talking about a target of 76% of A&E patients seen within 4 hours by next March. Will the Secretary of State tell me and my constituent why he thinks it is acceptable for patients to wait longer than is safe?
Well, firstly, we are bringing times down. I think the current mean response for C2s is much more in the region of 25 minutes, 26 minutes than what it was over the late December, early January period, because there was, as there was across the UK, a massive spike in flu, and she will have seen exactly the same in the Labour-run NHS in Wales. Over December, there's a 20% increase, for example, in 999 calls, but that is why we need to put in place greater resilience. That is what the plan I've set out to the House does.
Sir John Repland.
I strongly support the £1 billion for 5,000 additional beds and 800 more ambulances. It's long argued that with a growing population and a growing elderly population, we need more capacity. Is it also possible to take some of the 14 billion additional money also going in to provide even more capacity, because I think we're going to need it?
Well, I think what's within my right honourable friend's question is how we get more flow into hospital, because I think the key interaction around bed occupancy is once bed occupancy goes above a certain threshold, then actually that drives inefficiency within hospitals because of the lack of flow. That is why we're putting in the extra capacity. It's also about reducing those going to hospital in the first place and speeding up those who are fit to be discharged so that they can leave sooner. So whereas at the moment someone might, for example, sit on a ward for 3 doses of antibiotics a day, if those antibiotics, one continual dose can be administered through new kit at home, that's a much better patient experience, but it also relieves pressure on the wards.
Ezzy Cooper.
Mr. Speaker, I welcome the additional transparency on data for 12-hour wait times, because it's only by shining a light that we can see just how bad the problem is. But the targets set out in this plan today are utterly woeful. The Royal College of Emergency Medicine says that we need 13,000 beds. The government is offering 5,000. The percentage of patients that need to be seen within 4 hours should be 95%. The government is aiming for 76%. Heart attack and stroke victims should be seen within 18 minutes, and the government is only aiming for 30. Surely the truth of it is that this woeful lack of ambition means that our emergency care services are themselves on life support, and patients are going to continue to needlessly die for a very long time to come.
Well, firstly, can I thank the Honourable Lady for recognising the steps we've taken on transparency. I think that's been an area of challenge, and it is part of my wider commitment to transparency. On the ambition of the targets, I think they've got to be realistic, but it's not a ceiling, it's a floor. It's about saying, how do we set a target that's realistic? Of course, we'll aim to do better than that, but it's about setting something that the system feels is achievable, because that, in turn, gets much more buy-in. On the issue of beds, we are, as my right honourable friend alluded to, increasing the capacity. What it's really about is freeing up those patients who are fit to discharge from hospital, who shouldn't be there, and actually will prefer to be getting care at home. So it's about looking at the end-to-end bed capacity, not simply those within the acute sites.
Dave Riemann.
Thank you, Mr. Speaker. And can I welcome my right honourable friend's statement. In the pandemic, the use of local private hospitals, particularly in places like Basingstoke, by the NHS, kept services like cancer care going uninterrupted. Could the NHS be using more private facilities more widely to relieve some of the pressures that my right honourable friend has so eloquently outlined in his statement?
Well, my right honourable friend makes a really important point, and what's actually, again, within that is patient choice. How we empower more patient choice, providing services are free at the point of use, to use what capacity there is within the system, including the independent sector. So I absolutely agree we should be maximising the capacity. We had a very useful round table with the Prime Minister at Downing Street with the independent sector as to how we make more use of their capacity, and it's certainly an area we're exploring.
Derek Chway.
Thank you, Mr. Speaker. Mr. Speaker, I saw for myself only recently, a few weeks ago, the real crisis in our hospitals when I accompanied a close relative to Wiston Hospital and saw there on the corridors every single space taken up by a bed or a trolley or a chair. And quite frankly, what the staff were doing, the doctors, nurses, support staff, was quite amazing, and deserve all our praise for the hard work they're putting in. But it is shows we're in a sort of bizarre situation when the Secretary of State is lauding the fact that we virtually eliminated 2-year waits.
Yes.
Now, I do recall that when Labour left office, it was somewhat less than that, an 18-week target, and many people get seen within weeks, in fact, not just months as well. But let me ask the question to the Secretary of State this. He said they're on track to recruit 50,000 new nurses. Can I ask him how many nurses have left the NHS in the last 2 years?
Well, firstly, on the recognition of the staff, he's right to recognise the work that staff have been done. And in terms of the family member, again, when I made my statement earlier in January, I recognised there's been huge pressure on the system. We saw those flu numbers in terms of this spike of cases. He also sort of picks up on the point of the 2-year waits. The point I was there is simply contrasting the fact that there has been pressure on services across the United Kingdom, and the 2-year wait is far worse in Wales than it is in England. So if he's making the point in terms of why I'm referencing that, it's because we've cleared it in England, but the pandemic impacts have been there. In terms of recruitment and retention, that is why we're bringing forward the workforce plan to look at that. But the fact is we are recruiting more nurses, but that is also about meeting the demand pressure as well.
Simon Jupp.
There's no doubt the 5,000 extra beds will help support the NHS to provide the best possible patient care. Community hospitals across East Devon and our Nightingale and Exeter can play their part too. Does my right honourable friend agree that community hospitals can play a key role to help cut waiting lists?
I think community hospitals are absolutely key to tackling the issue of delayed discharge. I think community settings have been a bit of a Cinderella in the past. The data on community settings tends to be weaker than it is in other parts of the NHS. And I think alongside domiciliary care and making better use of residential care capacity, the third element is to look in terms of discharge at how we use community step down in a much more constricted way. But I think one of the key issues is to put wraparound services so people don't simply get transferred to the community setting, but that is a staging post before getting to the home, which is where most patients want to be.
Jeremy Corbyn.
Mr. Speaker, the social care sector is dominated by very dedicated staff who are paid very low wages, very high profits that are made from it, and an insufficiency of spaces. In the money that he's announced, will it go to local authorities? Can it be spent on public provision? And doesn't he think it's time to recognise the internal market and privatisation has sucked money out of health and social care, which could have been spent on patient care and caring for people both in the community and in special facilities?
Well, I think one area of his question that I do agree with him is the importance of local authorities. And one of the reasons I'm so keen to use more clarity on data and transparency is, I think sometimes there can be a tendency for the local authorities to be blamed for discharge, when often it's factors within the NHS as well that are contributing to some of those who are fit to leave hospital not doing so. In terms of the money allocation, the 2.8 billion is targeted to local authorities. So that is funding that the Chancellor set out for 4.7 billion the following year. So we are increasing the money for local authorities, but alongside that, we're working with them to improve the data so we can see where there are blockages due to local authorities. For example, and the Speaker will be familiar with this, but in Blackpool you quite often have people from out of area who visit Blackpool, and so they're dealing with a number of local authorities, not simply the local authority nearest to them. So we're working intently on how we support local authorities as part of the wider discharge package.
Sir David Abbott.
Speaker, I welcome my right honourable friend's statement and commend his approach to this very difficult problem that he faces and we as a nation face. Would he agree that while speeding up discharge from hospital and freeing up beds for patients needing urgent care and emergency care is absolutely necessary, there's a real need for the expansion of new services in the community, which must be a top priority. In my area, this is one of the biggest issues of why they're bed blocking in hospitals locally, because there's no community service to pick up when people go home.
My right honourable friend hits the nail on the head. He's absolutely right, which is how we better manage demand in the community before people get to the emergency department. And that is where, for example, action particularly targeted at the frail elderly is so important. But also how then, when people are fit to discharge, we enable them to do so sooner so that they can recover, whether in a community setting or ideally at home, with the right wraparound support.
Mr Speaker, the people of Bristol South will be ever so grateful to have data that they're waiting 12 hours rather than perhaps ringing me up to tell me they've been waiting 12 hours. He's a Treasury man. He must know that we are now paying more for less. So in the interest of transparency, can he be assured that in his own ICB, demand and capacity are matched, and he will know that? And how will I know that demand and capacity are matched in my own ICB?
Well, I think she was welcoming the 12 hours transparency. I certainly hope so. In terms of the ICBs, they became operational in July. We are working with them as to how, by taking a system-wide view, firstly, they can baseline where the gaps in data are. And one of the key areas of that is around the community side. So when she talks about matching capacity, part of that's understanding what virtual ward capacity, which conditions that applies to, what the physio wraparound services are, what's available within residential care versus community care, what the domiciliary care packages, as the Right Honourable Member for Islington North touched on in terms of local authorities. So we need to look at the data package across the piece on a system-wide basis. That's why we're setting control centres up. And then I'm very keen to make that much more transparent, because to be blunt, Mr Speaker, as a Secretary of State, you get the transparency anyway when things go wrong. So rather like her, I'd rather have much more transparent data so ICBs themselves can be better held to account. And indeed, that is what the Hewitt review is looking at in terms of that wider transparency piece.
Richard Villiers.
I really welcome the fact that Barnet Hospital Emergencies Department is going to be expanding and improving its facilities, it's taking on new staff, and of course I welcome today's announcement, but can I urge the Secretary of State, this must be effective on the ground soon. There is a real crisis out there. This is a good announcement, but it must be delivered so that patients and staff feel it at the front line as soon as possible.
Thursday.
I couldn't agree more, and indeed that's why the Prime Minister and I were at North Tees Hospital this morning, where it is effective on the ground. And so what it is about looking at where these measures have been effective at hospitals like North Tees, like Maidstone Hospital, and how we then take that best practice from those hospitals where it is having an effect on the ground, and we do what sometimes has been more difficult within the NHS, which is scale these innovations, get them adopted across the piece.
Mr Speaker, but there are 165,000 vacancies in social care. There was nothing in the statement about how the Secretary of State will address that. How will the Secretary of State address that? Better terms and conditions?
Well, the way we're dealing with that, Mr Speaker, is through the additional funding put in. So the 500 million for this winter, and it relates to the point a moment ago in terms of what impact on the ground, is to give ICBs and local authorities discretion. Some of that 500 million is being spent on workforce for example, in social care. So there is discretion as to how they spend that. And also in terms of then the funding that will be in place next year, the 2.8 billion of local authority funding and ICB funding that will be in place, and the 4.7 billion the following year.
Kevin Foster.
Thank you, Mr. Speaker. The Secretary of State will be aware that Torbay's demographics, particularly the growth in the numbers aged over 85 who are living to good long ages, but at that age needing at least some level of support from the NHS, is obviously creating demand and putting pressures on our systems. With the resources today, what engagement is he planning to have with local ICBs, particularly those who cover areas where the demographics are, shall we say, leading the age and have driven innovation but will need support in doing so?
Well, my honourable friend makes a very important and nuanced point, which is demographic pressure is not evenly spread. It's more concentrated in certain parts of the country than others, and therefore the pressure in terms of ICBs is greater in those areas. So that is why the ministerial team met almost all the ICBs in the run-up to Christmas. We had a series of meetings with chairs and chief execs as part of that discussion. And it's also why we want to bring greater transparency so we can see in terms of right-sizing solutions for the emergency department that those facilities are kept in pace with the increased demand.
Senator David.
Thank you, Mr. Speaker. Mr. Speaker, my constituent's 11-month-old son had to wait in A&E last night for 8 hours. They find this extremely unacceptable. The waiting experience in our hospital is like being in a disaster zone, and they're not my words, but the words of my constituent. My constituent went on to explain about parents having to sit on floors and wait for hours to be able to be seen, or their children to be able to be seen by a doctor. So I pressed the Minister, is there a plan to return to the standard of 95% of patients who come to A&E to be seen within 4 hours?
Well, as I said in my statement, Mr. Speaker, we're not setting out that ambition in this statement because the impact of the pandemic has been so severe. We need to set an ambition which is a target that is ambitious but achievable. And that is what we have done. But I refer to what, for example, the President of the Royal College of Emergency Medicine has said. This plan is a welcome and significant step on the road to recovery, and we're pleased to see it released. It's about taking best practice from those areas that are working and making sure those are socialised across the piece. But in terms of the specific case, obviously that is of concern to hear of those individual cases, which are obviously very traumatic for the families concerned. But that is why we have set out this plan and why we're putting in the extra funding.
Sir Julian Lewis.
In 2005 to 2006, there was a campaign within the NHS to close many inpatient beds in community hospitals. I was pleased by the Secretary of State's answer to a colleague earlier when he said community hospitals and beds there have a role to play. In that connection, will he consider again the future of the site of the Fenwick Hospital in Lyndhurst in my constituency, where the inpatient beds were closed and now the NHS is proposing to sell off the site? I would have thought that having a site like that and a bit of imagination could result in increased capacity.
Well, in terms of the individual decisions, that is what we're encouraging the integrated care boards to take ownership of, rather than trying to make all the decisions centrally from Westminster, that those closer to the ground, closer to the issues, actually are empowered to make the trade-offs, and I'm sure he will want to have those discussions with the chair and chief exec of his ICB. But the wider issue in terms of how we make greater use of community sites, not least given the workforce pressures and the different staffing ratios that those have, is absolutely the way that we help get more people out of hospital who are fit to leave.
Mr. Speaker, 10 days ago I shadowed one of the brilliant emergency department consultants at Derriford Hospital who are working their socks off under some very difficult conditions. The additional capacity for beds is welcome, especially because of the structural underfunding and a lack of beds in the southwest. But can I say to the Minister that the doctors and nurses were saying to me they want to slow the flow of people getting to the emergency department in the first place. So can he look again at the mothballed Cavell Centre programme, the Super Health Hub programme, that would have done so much to slow the flow, to deal with collapsing primary care services, and in particular look again at the government's decision to withdraw 41 million from the Super Health Hub from Plymouth. That would have been the national pioneer. That would have shown that this project works and would help our hospitals deal with the crisis they're facing.
So state.
Well, the substance of the point he makes is absolutely right. How do we slow the flow of people going to emergency departments? And then when people are fit to discharge, how do we accelerate that? So the substance he raises is absolutely valid and the right one. That is what schemes like the Community Service Response, the Force Service, looking at the likes of the North Tees model in terms of getting more staff into the community support, integrating the health and social care side together. As I said to my right honourable friend a moment ago, in terms of individual sites, those trade-offs are best determined by the ICBs, but I'm very happy with Ministerial colleagues to look at any specific proposals that it has, but it's really for the ICBs to be looking at how they best use their estate.
Thanks, Smith.
Thank you, Mr. Speaker. I warmly welcome my right honourable friend's clear and credible plan, but when it comes to the uplift of 800 ambulances, which is good news, can I urge him, when it comes to the deployment of those, to look at rural areas first, where the ambulances by definition spend much longer per patient on the road, going in between much more diversity spread out hospitals?
Well, I recognise the point he raises, not least as a rural constituency MP myself, and I think talking, as I'm sure he does, to paramedics, probably the principal cause of frustration of late hasn't been the issue of pay, important though that is, but it has been the frustration over long handover times, which has had a particularly damaging impact. I'm very happy to look at any specific issues within his own area, but he's right on the wider point as to the pressures in rural areas.
Thank you, Mr. Speaker. When can the people of Warrington and indeed Halton expect to hear about the new hospital campuses, which are much needed by both communities, with sufficient staff to resource them?
Well, in terms of this statement, Mr. Speaker, it's focused on the urgent and emergency care. Of course, at Health Orals and other occasions, we often discuss the wider capital programme, the increased funding that we're putting into that programme. And I think as part of that, it's also about outcomes, how we get more from that investment in capital. And that is why, through the NHS estate, we're starting to standardise our builds with the Hospital 2.0 programme as the first of those, and we'll be rolling that out more widely to the estate. I'm not familiar with the specific issues in terms of his local site, but I'm very happy to look at that following the statement.
Maggie Throop.
Mr. Speaker, I welcome this recovery plan and my honourable friend's comments on the role that community hospitals have to play in the future. The 16-bed Hopewell ward at Ilton Community Hospital was reopened ahead of this season's winter pressures, but it's due to be decommissioned in the spring. To aid with more efficient planning, will my honourable friend work with my local community health trust and my ICB to ensure these beds form part of the extra beds for next winter, but more importantly, that they become permanent rather than this ad hoc approach we've had up until now?
Well, again, Mr. Speaker, the decisions on the estate are principally for the ICBs, but I'm very happy to look at any individual proposals she has as to how we get more flow into the system, which in turn is about putting more capacity into the community.
Thank you, Mr. Speaker. I think I welcome what's being said about the mental health ambulances and trying to divert people with in mental health crisis from A&E. But I'm just a little concerned about whether the people attending the scene in those ambulances will have access to the past records or be able to carry out a risk assessment properly on people in that situation. So if you could reassure me on that, and also whether there will be places to take them to other than A&E. It's one thing saying that you want to divert them, but you do need to have those other resources in place.
Well, the Honourable Lady raises a very fair and important point in terms of what is the wider package alongside the mental health ambulances, which I think are a positive step. Last week I met Baroness Bushcombe in terms of the mental health pre-legislative scrutiny, in terms of the proposed legislation on mental health, which will pick up some of the points that she raises. And the sort of innovation is, for example, empowering people before they have a mental health crisis for example, on some of the apps that are being developed to put their statement of wishes, to put information that means that when they have a mental health crisis, that is actually very helpful for the paramedic crew. So we're looking at how we use innovation to better give voice to the patient and often do that before they have the mental health incident rather than when the ambulance arrives.
Tom Hunt.
Thank you, Mr. Speaker. I welcome the announcement today, and I think the key thing is it makes a difference in the short term. The Secretary of State will be aware of plans to build a new A&E department at Ipswich Hospital. The plan is for it to open January 2024. What assessment has been made about the difference that could make in the medium to long term in terms of increasing capacity and improving waiting times? And also, would the Secretary of State be prepared to work with me and Hospitals Trust to potentially even expedite plans so it may even happen slightly before January 2024?
Well, in a former role, Mr. Speaker, when I was Chief Secretary, I signed off a very significant expansion of A&E facilities, so I hope that reassures my honourable friend in terms of my commitment to putting more capacity into emergency departments, not least because they need a certain level of capacity to be able to put in the same-day access, the triage, the ways of getting flow into the system. In terms of, as I say, the wider site proposal, then clearly the ICB for his area will be wanting to prioritise that.
Ellen Morgan.
Thank you, Mr. Speaker. The urgent care and ambulance crisis has been brewing since autumn 2021 in Shropshire. And it's worsened since then. Last week, a doctor went on the record to say that the emergency department was like a war zone and that she feared that in a fire, not everyone would get out alive. In a 6-week period to the 12th of January, a Category 2 response time in Oswestry area was 2 hours and 10 minutes. So will the Secretary of State acknowledge that in some areas the crisis is worse than others? And will he agree to meet with me and the other MPs representing Shropshire to discuss how we progress Shropshire further along this track to solve the urgent care crisis that is so serious there?
I'm very happy to meet with the Honourable Lady and colleagues to discuss further, but I think most people recognise that since the huge pressures from flu over the Christmas period, those flu numbers have come down, but of course there is continued pressure in the system.
Sir Robert Butler.
Thank you, Mr. Speaker. I welcome my right honourable friend's statement. In particular, I welcome the announcement today of over £26 million of funding to expand the emergency department at Great Western Hospital in Swindon. He knows from his previous incarnation that we work together on this issue. It's particularly important not just for the integration of emergency services, but also the freeing up of other space within the hospital to allow for further beds or other clinical interventions. Does my right honourable friend agree that it is this sort of long-term measure that will guarantee future progress in our much-pressed National Health Service?
Well, my right honourable friend has been key to securing the funding. I know he has assiduously lobbied myself and ministerial colleagues to make a powerful case on behalf of his constituents. I think he should be very proud with the outcome that reflects his and his parliamentary colleagues' work on this issue. And he's right, and indeed the case he made was around how this frees up capacity in the system, which will result in much better care for patients in Swindon.
Tim Farron.
Thank you, Mr. Speaker. There is nothing in this plan to address the fact that there are thousands of people now turning up at A&E as a direct result of the fact that they cannot get regular access to an NHS dentist. Last week, another Cumbrian dental practice in Grange-over-Sands wrote to all of its 5,800 patients to say they had been forced to quit the NHS too. There is now not a single NHS dental place anywhere in Cumbria available. So what will he do to fix an NHS dentistry crisis that leaves a family of 4 having to cough up an extra £1,000 a year during a cost of living crisis to get access to the dental care they've already paid for through their taxes?
Well, I address this point, Mr. Speaker, in that we are bringing forward the third component of our 3 plans, the elective recovery plan, which I spoke about earlier, today's announcement on the urgent and emergency care recovery plan, and the third element will be the primary care recovery plan. And of course, alongside the work that we're doing on dentistry, it's also about access to services, both dentistry and in terms of A&E, and that comes together in things like the 111 and how we review that, and also the NHS app. So it's looking at the front door, how we better manage demand, and that demand for dentistry is both through NHS dentistry, but it also often manifests itself at A&E, with a lot of patients going forward for dentistry at A&E as well.
Anna Firth.
Thank you, Mr. Speaker. I warmly welcome my right honourable friend's plan this afternoon, in particular his focus on increasing capacity in urgent and emergency departments. I particularly welcome the government's recent investment of £8 million to reconfigure the A&E at my hospital in Southend. Would you agree this will increase not just the capacity but the quality of the urgent and emergency care on offer in Southend?
Well, I commend my honourable friend for her assiduous campaigning on behalf of her constituency in Southend, through which she has played a key role in securing the extra £8 million of funding, and she is right that that will make a material difference both to flow and capacity within the hospital and through that to the overall standard of patient care.
Jim Shannon. Can I thank the Secretary of State for his very clear commitment to extra funding for the Urgent and Emergency Care Recovery Plan. But will the Secretary of State outline if he is prepared to make additional funding available to meet the needs of maternity wards, which midwives feel that they are teetering on the brink, and which in reality means life and death due to staffing levels? And will the Secretary of State ensure this additional funding makes its way to each devolved nation under the Barclay consequential to be used before the scheduled new financial year ends? Thank you.
Well, as my honourable friend will know, through the Barclay consequentials, the additional funding that the Chancellor announced in the autumn statement will lead to an uplift in health funding for Northern Ireland through the Barclay consequentials. In terms of the flexibility within that, when I was Chief Secretary, he'll know that I agreed flexibility at that time. Of course, it will be for Treasury colleagues to look at what requirements there are for ongoing flexibility within Barclay consequentials.
You haven't.
Thank you. Can I warmly welcome what my right honourable friend has said today, and say that he's right to recognise that one of the long-term impediments to discharge is the disconnect between NHS and social care and local authorities. To ensure the additional money is well spent, can he confirm that the ICBs will not only be responsible for the establishment of the hubs and the extra care packages, but they will be properly monitored and held responsible for their performance and generating value for the extra money that's being put in?
Well, my right honourable friend, as former Minister in the Department, speaks with great experience on these, and he's right that the crux of the plan is now in the delivery of it, and as I alluded to in my statement, a key component of that is having more transparency on the data, so that he and colleagues across the House can hold the ICBs to account, but also the local authorities, and to bring those two data sets more closely in alignment.
Lynn Saxby.
Thank you, Mr Deputy Speaker, and I warmly welcome today's announcement, but I wonder if my right honourable friend could explain how, for remote rural hospitals like the fantastic North Devon District Hospital, the workforce challenges that were present pre-pandemic might be addressed post-pandemic, when we are now also dealing with a housing crisis, and might there be an opportunity to expedite the next phase of their redevelopment programme, which actually includes key worker housing?
Well, Mr Deputy Speaker, I'm very keen to explore with colleagues how we put more key worker accommodation onto the NHS estate, particularly making use of modern methods of construction to expedite that. In terms of the workforce plan, and Devon is an area that has seen a particular growth given its older population and greater pressure as a consequence, and those are pressures that will be worked through in the workforce plan that we're bringing forward shortly.
Can I ask the remaining members and those who are going to take part in the next statement, we're under a lot of pressure of time today, so please think of very short, focused, one single questions, please. Tobias Elwood.
Thank you very much, Mr Deputy Speaker. Can I welcome this statement, the extra investment in the NHS? It was a privilege to visit Bournemouth Hospital recently and meet the dedicated staff. As the Secretary of State will know, it's expanding with a new A&E facility. So could I ask the Secretary of State to come and visit Bournemouth, meet the staff and see the progress taking place?
Well, subject to diary, Mr Deputy, I'm very keen to visit, and if not myself, then I'm sure a ministerial colleague will do so.
Ruth Edwards.
Thank you, Mr Deputy Speaker. I welcome the £1 billion of funding announced today, and it's good to hear that hospitals have benefited from innovations like the patient flow control centres, care transfer hubs and virtual wards. So can my right honourable friend set out when Hospitals and ICBs, like Nottinghamshire, who have not been part of these pilots, will be able to access these innovations so that my constituents can start to access the benefits.
Well, they can start to access them now. So there is the 250 million we announced at the start of the month. There's part of the 500 million that was announced in the autumn statement, and they know that there is funding of 2.8 billion coming in terms of the new fiscal year. So there's an opportunity for them to move at pace.
Mr. Bridgen.
Thank you, Mr Deputy Speaker. The Secretary of State has told the House that the NHS was put under pressure with a spike in influenza cases in December. Could my right honourable friend tell the House where he thinks that influenza virus has been hiding for 2.5 years?
Well, Mr Deputy Speaker, I don't think it's been hiding. The flu seasons are not uncommon in the NHS. They come around on a periodic basis. That is why, indeed, we anticipated it through the flu vaccine. But perhaps to his wider point, I think it's also recognised as a consequence of COVID, some resistance may have been lowered in terms of flu, but flu pressures on the NHS are things that we've had in past years as well.
Mr. Pawsey.
Mr Speaker, I wonder whether the Secretary of State would consider more use of existing urgent care centres, such as at St Cross in Rugby. Our nearest full A&E is 12 miles away at UHCW in Coventry, which means that 83% of my constituents are more than 15 minutes drive away from A&E. And at Coventry, the hospital there serves a population of 600,000. That's twice the national average. So would he agree that extending provision at St Cross would go a long way to making a contribution towards reducing pressure at the hospital in Coventry?
Well, my honourable friend is right that not every patient accessing an emergency department needs a Tier 1 A&E facility, so it's about right place, right treatment in terms of the patient and making better use of urgent care centres and how they can better triage those patients that can be treated there is a key part of the plan we've set out.
Vickers.
Thank you, Mr Deputy Speaker. In Stockton South, we're incredibly grateful for the government's commitment to build a new diagnostic hospital so local people can get access to life-saving scans, tests and checks, and we're grateful for the £3 million announced to establish a new mental health crisis hub so that people can get support in their hour of need. But can my right honourable friend outline what he's doing to ensure that we have the right people with the right skills in the right place to deliver great service at these facilities?
Well, thanks to his assiduous campaigning, I'm delighted that he secured his diagnostic centre and also delighted, Mr Deputy Speaker, he assures me he is going to get it operational in one of the fastest times that any area has seen. In terms of workforce, we are bringing forward our workforce plan and as I said out in my statement, we've got 10,500 more nurses this year compared to last, and we're on track for our manifesto commitment of an extra 50,000 nurses with already over 30,000 recruited.
Mr Carter.
Thank you very much, Mr Deputy Speaker. Can I just take my right honourable friend back to the response he gave to the member for Weaver Vale a moment ago with regards to Warrington Hospital. It is an A&E unit that is incredibly under pressure. I spoke to nurses over the weekend who talked to me about the 120 patients currently waiting to be discharged, which is putting intolerable pressure on the A&E unit. He said he wasn't particularly familiar with it. Perhaps I can invite him to Warrington to come and see the pressure there. And while he's there, perhaps he could also look at the Health and Social Care Academy that the local college has set up to try and address the shortage in social care. It certainly seems a great level of innovation that's happening there. I'm sure he'd like to see Warrington for himself.
Well, Mr Deputy, what may be the last question, it gives me a beautiful opportunity to correct an early answer because I was just placing the honourable member's constituent. He knows I'm familiar with it because I remember calling him about 10:30 one evening to discuss his A&E when there's some particular issues that have come to the attention of the media. So I am very familiar with the pressures on his hospital. I was just placing the honourable gentleman's constituency vis-à-vis my neighbours. So clarified on place, I am familiar with the fact it is under pressure, and I know the Minister of State is due to visit, and I'm sure she will look forward to meeting both members when she does so.
I'd like to thank the Secretary of State for his statement and responding to questions for over an hour. We're now going to move on to the next statement. As I said, please, you can see how many people are standing, and we are likely to sit beyond midnight tonight, so please focus. Michael Gove.
Thank you very much, Mr Deputy Speaker. And with your permission, I should like to make a statement which allows me to update the House on the government's progress in making buildings safe. It's a basic requirement of any civilised society that people should feel safe in their own homes. But for too many people, for far too long, that has not been the case. As I've said before, so I say again today, this has been a collective failure. Those in government who made the rules did not make them clear enough. Those who built our homes did not build them well enough. Those who made the materials which contributed to the construction of these homes often made them unsafe, at times knowingly. And those who were to check the work that was undertaken didn't always check thoroughly enough. And of course, those who own the buildings have sometimes managed them so poorly that people have been left unsafe, and too many of these owners have still shirked their obligations to make people safe. The only party to this crisis which does not share in the responsibility are the blameless leaseholders and the tenants who live in these buildings. That's why it's right that this Parliament protected these leaseholders through the Building Safety Act and apportioned financial responsibility more fairly. And we continue to work to make sure that those who bear the blame for this crisis also shoulder the burden of putting the situation right. And Mr. Deputy Speaker, we have made significant progress. Those who put unsafe material on people's homes must now pay, instead of the innocent residents living in them. Leaseholders need no longer fear financial ruin simply to make their homes safe. And the major mortgage lenders, thanks to their confidence in our new approach, will now lend on properties that are covered by the leaseholder protections in the Building Safety Act. And of course, they will also lend where the building is eligible for a government or developer remediation scheme. So leaseholders are no longer hostages of their mortgage arrangements. We have also reopened and turbocharged the Building Safety Fund for new applications, and we're piloting our Medium Rise Fund, paid for from a levy on developers, to ensure that dangerous cladding will be removed. Leaseholders can rest assured that their buildings will be made safe. And where remediation is required and building owners are sitting on their hands, even when money is being provided by the government, we will use powers under the Act to force the owners to fix their unsafe buildings. There should be in no doubt there will be significant consequences for those who fail to comply with their legal obligations. Leaseholders should know the law is on their side, and today we make further progress on delivery. In April last year, I announced that the largest house builders had signed a pledge committing to fix all life-critical fire safety issues, internal and external, in buildings over 11 metres, which they had a role in developing or refurbishing in England. Developers also committed to reimburse the taxpayer where that work has already been done and subsidised by the taxpayer. In the summer, my department published the draft contract that will bind developers to honour that pledge. Since then, my officials have been working through that contract line by line to ensure that it codifies the pledge in a way that is fair and transparent, committing developers to fix buildings for which they are responsible as swiftly as possible, and therefore keeping residents and leaseholders informed about that work. I'm grateful to all of the developers who work with us and to the Home Builders Federation and, of course, their chairman, Stuart Paisley, who've worked so hard in order to make sure that this contract can deliver. And today we're publishing the final contract that I expect housing developers to sign. A copy of the contract has been deposited in the library of each house and is available on gov.uk. Let me be clear. If you're one of the developers that we invited to submit comments on the contract, I now expect you to sign it within the next 6 weeks, by March the 13th. That includes every company that signed the original pledge, as well as several companies that have regrettably not done so. Now is the time for all of them to make a binding commitment. This commitment will not only see them do right by those whose homes they've blighted so far, but it will also help them to maintain their credibility with those who may seek to contract with them or consider buying their homes in the future. Those who fail to step up and make this commitment will suffer the consequences that this Parliament has so clearly spelled out. Using powers provided by the Building Safety Act, I will lay regulations this spring to create a new responsible actors scheme. These regulations will set out which developers, by signing the contract, are eligible to be members. Those who built unsafe buildings, we expect to sign this contract. To join the scheme, they will have to sign and comply with the terms of the contract published today. And of course, we'll invite developers to join the scheme in order to ensure that we do right by leaseholders. Anyone who fails to sign the contract will be prohibited from carrying out future development and from receiving building control sign-offs for buildings under construction. Mr. Deputy Speaker, if you're a developer, if you fail to sign this contract, you will have to find another line of work. And I'm saying to all developers who've built unsafe buildings over 11 metres that I'm putting you on notice. You will be asked to step up. I will consult in due course on how we expand the responsible actor scheme to make sure that we capture all of those who built unsafe buildings and should now fix them. Altogether, I expect developer remediation to be worth more than £2 billion of investment in safety and will protect those in hundreds of buildings. I'm grateful to those in the development community who've got on with assessing and remediating their buildings without waiting for the final formal contract. I welcome their constructive engagement, but all developers should recognise that in signing this contract, they take a big step towards restoring confidence in the construction sector and providing much needed certainty to all concerned. Those who sign will confirm that they're responsible companies, and I know from the positive discussions I've had that many are now keen to sign, and I want particularly to thank all those developers who have today confirmed that they will be signing. Accepting their new responsibilities will allow developers to plan ahead in the knowledge that they now understand the full extent of their legal obligations. When these buildings are safe,